Hello everyone, my name is Satyajit. I'm professor of HIV medicine and a consultant physician in a teaching hospital in UK. Today, I'm going to present a very interesting case on behalf of my friend, a long-term friend, Dr. Angshu Prakash Saha, who is a well-known practitioner, specialist in the field of family medicine or community medicine. The purpose of this presentation is to share our learning with each other, to share our knowledge we have gathered from the long time we spent in the different fields of medicine in different parts of the world. So let's go straight to the case. A 35-year-old male farmer from a village in India who is normally fit and healthy presented with a 6-month history of ongoing dizziness with increased sweating, with palpitation, fine tremor, and agitation at times. Family members noted abnormal behavior becoming aggressive sometimes. He has increased craving for food, particularly sweets. He possibly had fits in 2 occasions in last 1 month. He sometimes complains of double vision and blurring of vision, and the symptoms are worse in the morning and in the evening after he comes back from the farm. He drinks country liquor every evening. He smokes cigarettes, occasionally with weeds. He denies taking any other illicit drugs. He lives with his mother, and his mother suffers from type 2 diabetes, and she is on oral hypoglycemics. His history of past medical illness and family illness are otherwise unremarkable, and he is normally known as a decent, hard-working man. Because of his abnormal behavior, he was referred to a psychiatrist, and he has been prescribed with some anxiety-relieving tablets, but without any effect. Because of his ongoing or recent problems of fit and double vision or blurring of vision, he was also seen by a neurologist, and he had CT and MRI scan of the head, which were normal, and he was prescribed with some anti-epileptic medicine. At this point, this patient was seen by Dr. Saha, and he came along with his brother. From the very beginning, the patient seems to be very apprehensive, but otherwise he admitted most of the symptoms. His systemic examination was unremarkable. He didn't have any temperature, and pulse and blood pressure and hemodynamic status were within normal range. He came up with a bag of reports, bunch of reports, including CT and MRI. Dr. Saha went with all the reports. But one report Dr. Saha was looking for was missing. Could you guess what that report was? Is it full blood count? Is it UNEs and LFT? Is it blood sugar? Is it thyroid function test? Or is it 24-hour ECG report? Yes, you're right. It is the blood sugar report, and the fasting blood sugar was 40 milligram per deciliter, much lower than normal. So, at this point, can you guess what is the diagnosis? Is it factitious hypoglycemia, that is, he is taking medicines from his mum? Is it hypoglycemia due to chronic alcoholism? Is it autoimmune hypoglycemia? Is it insulinoma? Or is it hysteria with pseudo-hypoglycemia? So Dr. Saha advised some tests. Obviously, that included HbA1c, which was 28, lower than normal. C-peptide was raised, and plasma insulin was raised too. So he then asked for a CT abdomen, and the CT abdomen showed a small mass in the tail of the pancreas. Here I am showing you a CT abdomen with a typical example of a mass in the tail of the pancreas, as pointed out with a green mark. It is worth mentioning here that this particular CT scan is not from the patient we are discussing here, but I'm sharing you from my own slide collection. So here is a patient who has symptoms of hypoglycemia and confirmed with blood test showing hypoglycemia, and the symptoms improve with food, with raised C-peptide and plasma insulin level, and CT abdomen showing a tumor in the tail of the pancreas. Adding all together, the patient had insulinoma. And Dr. Saha at this point referred the patient to the endocrinology team, and subsequently the patient had surgery with good outcome. So a little bit about insulinoma. Insulinoma is a neuroendocrine tumor deriving mainly from pancreatic islet cells that secretes insulin. Some insulinomas can also secrete or can be associated with increased secretion of other hormones like gastrin or 5-hydroxyindole acetic acid or ACTH, glucagon, human chorionic gonadotrophins, and somatostatin, and few other hormones as well. And the tumor may secrete insulin in short bursts, causing wide fluctuations in blood levels. There is a terminology which is often used to diagnose insulinoma. It is called Whipple's triad or Whipple's criteria. That includes: number 1, symptoms known or likely to be caused by hypoglycemia, especially after fasting or heavy exercise. Number 2, a low plasma glucose measured at the time of symptoms. And number 3, relief of symptoms when glucose level is raised. Insulinomas are the most common cause of hypoglycemia resulting from endogenous hyperinsulinemia. Approximately 90 to 95% of insulinomas are benign, and long-term cure with total resolution of preoperative symptoms is expected after complete resection. There are a lot of literature available, and here I have mentioned one paper which is very useful and freely available from online, and also I have got some online information which is freely available and you can access. So in summary, we saw that a gentleman who presented with dizziness initially with some symptoms of palpitation, tremor, etc., which can be related to hypoglycemia. He went for neuropsychiatric review, but a fundamental basic test was missing. And Dr. Saha did the very important thing, looking for the fasting blood sugar and pointing the patient quickly to the right direction with a very good outcome. Again, I am sure you all have good cases and good experiences in your long clinical career, and please share with us your experience and your knowledge so that we can learn from each other. After all, knowledge has got no limit and knowledge has got no boundary. So at this point, I am sure you will all join with me in wishing good luck for the patient and also congratulating Dr. Saha for managing this patient efficiently and quickly. I enjoyed this case and I hope you have enjoyed this case. Thanks for watching this video. Bye for now.